Welcome to the Translational Applications in Public Health lecture, which is a collaboration between the Institute for Public Health and Medicine and the Northwestern University Clinical and Translational Sciences Institute. My name is Leah Welty. I am a professor in the Division of Biostatistics and Informatics in the Department of Preventive Medicine. I direct the Biostatistics Collaboration Center, and I have strong ties to both IFAM and NUCATS. So I am very pleased to be here today. I want to thank everyone for joining us. Just some housekeeping items. During today's presentation, please use the Q&A function if you are online rather than the chat to submit any questions. We will also have time at the end of the presentation for Q&A. So now it is my great pleasure to introduce my colleague, Lucia Petito. Dr. Petito is an assistant professor in the Division of Biostatistics and Informatics in the Department of Preventive Medicine. She is also affiliated with the Biostatistics Collaboration Center. She has her BS in mathematics from the University of Rochester, her MA and PhD in biostatistics from UC Berkeley, and she completed a postdoctoral fellowship in the program in causal inference at the Harvard H.T. Chan School of Public Health. She joined our faculty in 2019 and has collaborated with investigators across a wide range of epidemiologic studies, many of them in cardiovascular health. She is an expert in causal methods, and in particular using longitudinal observational data, such as electronic health records, to draw important and robust conclusions, which she's going to tell us about today. So one fun fact, not only is she an accomplished biostatistician, she is, in her not so copious spare time, also an accomplished violinist. So with that, welcome, Dr. Petito.
Okay, great. I am very pleased to be here. Thank you very much for the invitation. I am going to preface my talk by saying that I'm getting over pneumonia, so I apologize. I chose the handheld mic so that I can turn it off if I need to step away for a moment. Okay, so today we are going to be talking about causal inference broadly from observational data and a new framework that has recently become very popular called the target trial framework. My talk is going to be in broad strokes in about 5 pieces. I will tell you all what I mean when I say causal inference. I'll talk about why people who study causal inference really like randomized trials a lot. I'll talk about some common issues that we encounter when we try to do causal analyses and observational data. And then I will talk about what the target trial framework is and give an example of a target trial that I recently completed with my colleague, Dr. Otto Rivera, where we studied new statin initiation and COVID-19 outcomes. Okay, so causal inference, what is our goal? Most of the time when people talk about causal inference, they really mean that they want to estimate the causal effect of some particular action, doing the action versus not doing the action on a particular outcome. And everybody wants to do it. So my husband is a chemist, and he always tells me that if he runs the same reaction at 2 different temperatures, that if he sees a difference in the yield of that reaction, he can directly attribute it to the difference in temperature. And that's because his experiments are run in a closed system where he has the ability to control and manipulate all aspects of the experiment. I work in what I will lovingly refer to as a soft science. And by that, I mean lots of studies in epidemiology, public health, economics, or sociology. And in those settings, oftentimes we're interested in drawing causal effects but we are not able to closely control all aspects of our experiment. Another point that I always make at the beginning of causal inference talks is that there is a lot of research that happens in public health and epidemiology that is very important, but it is not causal. So examples of causal questions are things like, does liver transplant surgery increase the life expectancy of individuals with cirrhosis? I can very clearly imagine transplant recipients versus not transplant recipients, following them, measuring their life expectancy, and comparing it between the two groups. There are non-causal questions that are important, right? I mean, we need to be able to estimate the burden of disease in populations. So counting problems, I would argue, are not particularly causal. How many people in the United States have early onset dementia? Very important for informing public health interventions, not causal inference. I would also argue that there are some prediction questions that are also not inherently causal. So you might be interested in whether or not you can predict an inpatient outcome using EHR data that's collected at hospital admission. Can totally imagine building like some sort of a machine learning prediction model for that. But at the end of the day, you're not asking if you can manipulate anything about the patients at their hospital admission to change their outcome potentially. So we don't think of that as a causal question. I did throw some cartoons into this presentation. For those of you who are not familiar, this is a very famous one. I used to think correlation implied causation. Then I took a statistics class. Now I don't. Sounds like the class helped. Well, maybe. I feel like that all the time. And I've taken my fair share of statistics classes. So back to what we talk about when we think of causal inference. The motivation, my motivation, and the motivation of many of my colleagues is to make decisions in medicine. And that can fall under a lot of categories, but the specific studies that I work on tend to fall under comparative effectiveness of different treatment options or policy effects. So if I enact this policy, would I change the outcomes of patients who received that policy? And when we think about these questions, even before we start to collect data to answer them, we typically think about how we would design a randomized controlled trial in order to answer those questions. And the randomized trial, as many of you are aware, is really considered the gold standard for evidence generation. So you probably have seen this evidence pyramid many times in your life, but just as a refresher, the bottom two rows are what we would lovingly refer to as anecdotes, editorials or expert opinions, or case series and case reports, but typically on a very small number of patients. Then we run into the classic observational studies, such as case control studies and cohort studies. And then the orange, we get randomized control trials. And really that little triangle right at the top, people usually refer to as meta-analyses of randomized trials. And that kind of synthesis of multiple randomized trials is considered the gold standard. So I don't know if you all are aware, but as you start thinking about moving into the space of causal inference and observational studies, you quickly run into barriers, let's say, when submitting your final study results to journals, because many of the journals follow the guidance laid out by the AMA Manual of Style, which says that causal language should be reserved essentially only for randomized trials. And they have really focused on this one aspect of study design. There are so many other things that go into data collection that could possibly go wrong. But the medical journals have basically said we can only use causal language and talk about impacts or relationships or effects when we're talking about a randomized exposure. By the way, I pulled this language from the JAMA Network author guidance webpage on Tuesday this week. So that's important later in my talk. So why have we glommed on to randomization as this great study feature? So this is yet another comic that I really enjoy. Step 1, come up with a new idea. Step 2, convince people that your idea is good. And step 3, adopt the new idea. And people always want to skip that step where you check whether or not it works. So why do we like randomized trials? So let's do our first thought experiment. You're designing a study. You decide you're going to recruit some number of participants, say 100. You're going to randomize them 1-to-1 to receive a vaccine, a one-time shot, or a saline shot, like placebo, right? And then all of those people are going to come into your clinic. They're all going to receive their shot, whether it's the vaccine shot or the placebo shot. And then you're going to be able to magically follow all 100 people for a whole year. And then you're going to pick up the phone, you're going to call all of them, you're going to ask them whatever outcome it is that you're studying, and you're going to get perfect retention. Okay. Then if we analyze that study according to the intention to treat principle, meaning analyze them according to the treatment arm they were assigned to and received, then we're pretty convinced that the effect that we get is going to reflect the effect of receiving the vaccine versus receiving the placebo. So now let's go back to the beginning. Let's imagine a slightly less perfect trial. And in this trial, I'm also able to magically recruit 100 participants. I randomize them 1-to-1 to taking some drug, let's say for 3 months, or taking sugar pills, let's say for three months. Again, I'm able to follow them for a whole year. I call them all 365 days later. They tell me whether or not they had the outcome I'm interested in. And then I'm kind of stuck. So I can analyze that data according to the intention to treat principle. I can say, I randomized half of these 50 people to take this drug. I randomized 50 people to the sugar pills. I can ask what's the difference in outcomes among these people. But that intention to treat effect may not actually reflect the per protocol effect, meaning the effect of taking the drug for 3 months or taking the sugar pills for 3 months, because there may have been imperfect adherence, right? People may have forgotten to take their drug. They may have not wanted to take the drug because they got some sort of side effects. But because adherence to that protocol happens after randomization, I'm no longer afforded the same protections that randomization guarantees about exchangeability of my treatment arms. And so in order to estimate those kinds of effects, we think about per protocol analyses, which are slightly different than intention to treat analyses. So I'm going to tie those concepts now back to our fundamental assumptions that we like to make in causal inference. And these are called exchangeability, positivity, and consistency. And you probably never need to remember them outside of this room, but I'm just going to tell you what is on my mind when I think about designing studies. So what is exchangeability, right? It means essentially that the two groups are exchangeable. I want to be sure that there's no unmeasured confounding. I want to understand how the treatment was allocated. And I want to make sure that there's no selection bias, meaning that I'm not conditioning or restricting on things that are a common effect of the exposure and outcome, or things that cause the outcome. Basically, things that happen after that initial randomization. The second, oh, and I need to do my plug. So these cartoons are drawn by one of my colleagues who's named Ellie Murray. She's faculty at Boston University. She's on Twitter, or I guess it's called X now, at EpiEllie, and she does really good science communication. I encourage you to check it out. So when we think about positivity, what we mean is that for every person that we enroll in our trial, we want there to be positive probability that they receive every treatment we're thinking about. So for example, we would not include somebody where we always treat if they're pregnant. We would not include somebody where we would never treat them with one of the treatments because they're allergic to it. We're only interested in the people who we would sometimes treat. So for example, this last little guy is, we would sometimes give them opioids if they're in pain, but we might also give them something else. Okay. The last is what we call consistency. And consistency essentially boils down to really clear specification of exactly what the treatments are that you will be assigning and what the outcome is that you'll be ascertaining. So a question that is a reasonable question to ask, but is not inherently causal is, does high cholesterol cause heart attacks? A question that has a manipulable exposure is, will a cholesterol lowering drug reduce the risk of a heart attack? That's something that I can imagine designing a trial to answer. So why do we like randomized trials so much? Well, if we imagine our hypothetical vaccine trial, where we know whether or not everybody got the particular vaccine versus the placebo, we know that randomization ensures no confounding at baseline because I have flipped a coin in order to assign people's treatment. It ensures positivity for a treatment assignment because that coin has a chance of turning up heads or tails for every person. It's a well-defined intervention. I can write down the probability that you receive the vaccine is 50% if it's a fair coin, or could be more or less if it's an unfair coin. And most importantly, when we think about intention to treat analyses, particularly for that vaccine trial, they will provide, in most scenarios, an unbiased estimate of intention to treat effects, assuming everything else goes perfectly, which is a big assumption. But for our hypothetical drug trial, we need to stop and think about the study design a little bit more carefully, because adherence to the protocol they're assigned to happens after randomization, and loss to follow-up happens after randomization. And these things that happen after that initial randomization are not guaranteed to be unconfounded. So, okay, now I hope I've convinced you in causal inference. We do really like and respect randomized trials. I have lots of colleagues who spend their lives working in causal inference for randomized trials. But that said, sometimes there are scenarios where we cannot conduct a randomized trial. They can be extremely expensive. I saw a paper somewhere that said the average cost of a clinical trial these days is $12 million. That is a huge amount of money. So it may not be possible. The second, sometimes you're interested in studying outcomes that take a really long time to develop. So for example, you are probably all aware that when you turn 50, they recommend that you go get your first colon cancer screening, go get a colonoscopy. And then they have some recommendations about when you should or should not come back based on what they find at that first screening. But the strategies for timing of colorectal cancer screenings actually only recently have been studied via a randomized trial. It was done in some Scandinavian country, I believe maybe Sweden or possibly Norway. I forget. But the point is that when you study incident colon cancer after a screening, you're waiting a very long time for that colon cancer to develop. And in the meantime, doctors who work in places like Northwestern are making decisions about when people should and should not be screened. And so sometimes it's helpful to have evidence that comes from other sources when evidence from a randomized trial is not available. The last is, of course, I'm sure I don't have to convince many of you that smoking causes lung cancer. Although there were several statisticians who were avid smokers in the 1960s who fought very hard to get smoking not called a cause of lung cancer in Congress. But that initial evidence did not come from a randomized trial. You better believe me, there's never been a trial where we randomized humans to smoke cigarettes versus not, and then followed them to see if they get lung cancer. But in the 1940s, after the soldiers from World War II came home, doctors started noticing that the soldiers who had black lung, or whatever they were calling it at the time, were overwhelmingly smokers. And so they actually, I believe that evidence first comes from case control studies. So even if you are able to design and get funded a perfectly designed randomized trial, there are many other things that can go wrong along the way. So first, like I said before, there may be imperfect protocol adherence. And when you run into imperfect protocol adherence, the red flag that goes off in people like my heads is that the intention to treat effect that you can and probably will estimate from that trial may not actually reflect the effect of perfect adherence to that study protocol that you had set out. Another thing that can happen and happens frequently is differential outcome ascertainment. So you all are probably familiar with these flow charts. You assess a certain population for study eligibility, you randomize a subset of that. And then even then, there are many places in the pipeline where people may fall out. So the sample that you analyze at the end may be smaller than what you started with. And the people who fall out may be different in arm A than they are in arm B, right? And so that is what we call selection bias. And the last is that people who are willing to participate in trials may be systematically different than the target population that the intervention is geared towards. And so that is something that we call limited generalizability. And there are a bunch of new causal inference methods for transporting estimates from population with one set of baseline characteristics to a new population whose baseline characteristics may look slightly different. And those studies are typically either called generalizability studies or transportability studies. Okay, so trials are great. Sometimes trials have problems. But observational data analyses can cause so many headaches. Story of my life. So what can we do that's not a trial? We can use observational data to answer our questions. And I like to think of these studies as falling broadly into two different buckets. The first are classic epidemiologic studies. I work on lots and lots of cohort studies where we enrolled a bunch of people a long time ago, and we are still following them up 20 or 35 years later. The other, which I will be talking about a little bit more today, are what I call found data, which are just systematically collected health data that were not initially collected for research purposes. And those studies, broadly speaking, fall into several buckets, but include electronic health records, administrative insurance claims databases, and national registers. And what our goal is when we are trying to do causal inference in observational studies is we want to be able to conceptualize the observational studies as conditionally randomized experiments, meaning that if I have collected enough information about what these people look like at enrollment. I'm going to use some air quotes there because enrollment may look different depending on the data source. I want to be able to say that the two groups of people that I identify look pretty similar at the baseline. I also always add a caveat in these talks, which is to say these analyses are not our preferred choice. We do like to run trials when we can. It's just that it's not always possible. So the question then becomes, when do associational measures, like what we see if we were to just take some observational data and run a logistic regression model, when do those associational measures equal causal measures, right? And a good way to kind of distinguish between these two, and I understand that this thing does something cool. Let's see. Oop, did it do it? Did it do it? There we go. You can see the red dot. So this square here represents our population of interest. And in our typical observational analysis, we would basically estimate the average outcome among people who received the treatment, and we'd compare it to the average outcome among the people who did not receive the treatment. But in causal inference, the questions we're asking are really, what would the average outcome have been in the population if everybody had been treated, versus what would the average effect have been, or excuse me, the average outcome have been in the population had everybody not been treated. And those are slightly different quantities, and we make some assumptions about how to get back and forth. But broadly speaking, there are certain things that we always have to worry about when we do observational causal inference. The first is confounding, and I'll talk more about confounding in a moment. The second is selection bias, which essentially comes down to differential loss to follow-up between the two groups, or whether or not our groups have been selected even at the point of enrollment. So for example, in some studies, you might compare prevalent users of a drug to never users of a drug, but the prevalent users probably already, the people who are on it at a particular point in time, probably don't include the people who started it, had bad side effects, stopped it, right? And so you might already have a selected population at baseline. And then the third, which you should always worry about, but I'm not really talking about so much today, is measurement error. And measurement error may occur in the outcome variable, the treatment variable, and the confounders. We primarily worry about it for the outcome and the treatment variables. And in particular, we're worried about differential measurement error, meaning that we did a better job of capturing it for the treated people than the not treated people. So, confounding. Confounding is the bias that arises when we make causal inferences based on comparing groups that are not comparable. It's everywhere. So, a couple of examples here. Kids of teen moms are less likely to finish high school. Well, is it cause and effect? Are we implying here that teen moms don't raise their kids as well as older moms? Or is it confounding? Teen moms tend to live in more disadvantaged environments than older moms. Another one, very common, educated people earn more money. Okay, well, it could be causal. Maybe formal education teaches skills and provides some sort of a network so that you have access to better jobs. Or is it confounding, and people who have intrinsic, high motivation and who are well connected, maybe they're more likely to seek education. So when we think about, because I'm giving a high level overview here, observational studies will always have some degree of unmeasured confounding. And there's basically a couple of different kinds of ways that we try to combat that. First, In a lot of these studies, we do what we call falsification analyses, which is we swap out our primary outcome from our study for either a positive control or a negative control outcome. And when I say, negative control outcome, it should be a variable that has a similar confounding structure as the exposure and the primary study outcome. But you would expect there to be a null effect. A lot of times in health systems, I see people using things like whether or not somebody received their annual flu shot. And then another thing that people can do if they believe that they really can't get a handle on the confounding in their situation is they'll conduct a instrumental variable analysis. Has some caveats, local average treatment effects don't always approximate average treatment effects. That's kind of a technical detail. A bigger issue that you probably have encountered is that most instruments are imperfect, but actually the best example of an instrument is randomization, right? Randomization is the instrument for the actual protocol of the study that you are going to conduct. So, sure. Yeah, so the question was whether propensity score matching also fits here. The answer is yes, it can. Although propensity score matching addresses the exchangeability of the groups, but doesn't necessarily prevent selection bias or address anything about measurement error. So the other thing that most people end up doing, frankly, is just adjustment. And I don't want to say throw the kitchen sink at it, but it's not a bad place to start and is often the easiest place to start. So in my experience, while unmeasured confounding is a problem, and we should always be thinking about it, it's often not the biggest issue with observational studies. And in my limited experience, selection bias, and particularly the assignment of baseline time for the analysis often makes a much bigger difference in the effects that you estimate because it changes the population of people you're including in your study. So, why are we talking about this today? Well, recently, like a couple months ago, there was a big deal paper, editorial piece that came out in JAMA that said, yes, we realize that in our author guidelines, we limit the use of causal language to randomized trials, but we should be aware that there have been a lot of advancements in observational causal inference over the last 50 years. And there are some places where really high quality observational studies are being done in places where we can't run trials, and JAMA should be open to publishing those studies as well. Now, I haven't seen any studies like that yet, but I can be optimistic for the future. So one of those advances, and something that has really, I want to say, like facilitated conversations between people like me who are more analytically inclined and my colleagues who tend to be medical doctors, is something called the target trial framework. And so I always like to be I like to rib my postdoc advisor a little bit. So when I started in his group, he gave a talk that was called a two-step algorithm for causal inference. And I saw the sign and I was like, oh, he's just a little bit more flippant about this stuff than I am. But he started the talk by saying, here's my two-step algorithm. Step 1, ask a causal question. And step 2 is answer that question. And while he is correct that technically that is a two-step algorithm, that It's a lot more complicated than that. So what does he really mean? Well, step one, thought experiment, right? Imagine a hypothetical randomized trial that we would prefer to conduct and analyze. And we're going to call that quantity the target trial. And basically, what this does is it strips away all of our considerations about the data that we have in front of us, which always confuse the matter, and just says, I have a particular scientific question I'm interested in answering. I need to design a trial in order to answer that question. And once you've done that step, which can take a really long time, I'm helping with a grant submission for a target trial, and we started our discussions of this in the middle of July, and we centered on all of the details of the target trial last week. So many conversations back and forth. Once we've designed the target trial, we have a choice, right? We can either write a $12 million grant to NIH asking them for money to conduct our trial, which is a thing that some of my colleagues do. Or we can decide that really it's not practical to run a trial, either because we won't be able to recruit people or because it's not worth it for other reasons. And we can decide to analyze found data as an attempt to emulate that target trial. So a caveat here is that we can never hope to emulate a tightly monitored, placebo-controlled randomized trial using observational data. We tend to try to emulate pragmatic trials instead. And I'm going to make a small detour here, which is when I started my job, which was 5 years ago at this point, I was sitting in my office and my colleague came in and said, she was the statistician for this trial, but she had had another project funded, and would I be interested in taking the trial? And I said yes to her. And then I sat in my office and I thought to myself, I know nothing about trials. I never took a class on how to run a randomized trial. I wonder what I've gotten myself into. And it turns out that there is so much guidance on what the role of a statistician is in a trial. And a big piece of the work that the statistician does in the first couple of years is they detail what the study protocol is, right? And they talk about what the details are around outcome ascertainment. They talk about details around the statistical analysis plan. And then they publish it, which is mind-blowing to me because I came from, nutritional epidemiology and pregnancy-related epidemiology, where we do not publish protocols for observational studies that are secondary analyses of cohorts that already exist, right? That's just not something we do. And I just point this out because there are real places where all they do is they publish study protocols. And so contemporary clinical trials and clinical trials are kind of the two main journals, but there's also all sorts of recommendations. There are checklists that you can go through to make sure you've done all the work. It's very interesting to me. I say all of this because my first introduction to a study protocol was when I learned about target trials. And so for a target trial, the idea is that you would design, I'm going to use air quotes there, but you would design the hypothetical trial that you're interested in running. And so what does that mean? That means you need to explain exactly who would be enrolled. That's eligibility criteria. You need to tell us what you would do to these people. So what are the treatment strategies they would be randomized to? And how would they be assigned? Would they be randomized on a patient level, at a clinic level? Are you going to do block randomization? Are you going to stratify randomization? All that kind of stuff. The next is, how long are you planning to follow up these patients? Are you going to follow them for 6 months, for 5 years? You need to define particularly what you're going to measure about these people. So what the outcomes are. And then you need to be specific about how you plan to analyze that data. What is the causal contrast of interests that you're looking at? And how are you going to estimate those particular effects? And so once you've done that for your hypothetical trial, the question then becomes, how do I need to change those components in order to emulate that trial in found data? And so the first step whenever we run a target trial is to detail what the target trial is and how that target trial will differ when we do our observational analysis. And I will say, I always put this picture in here because I think it kind of helps people to understand. But one of the major strengths of the target trial framework is that it really forces you to align the ascertainment of your eligibility criteria with the beginning of follow-up and the point at which treatment is determined. Because when you misalign them, kind of as shown here, you can actually self-inflict immortal time bias and prevalent user bias and other kinds of selection bias. I highly recommend the paper that's linked at the bottom of this slide. It's a paper from 2016 that's titled something like that, like using the target trial framework prevents self-inflicted biases or something like that. But it's very helpful to kind of understand what can go wrong. I will also make the same caveat, which is that the target trial framework does not prevent confounding bias due to non-comparability of treatment groups. So whenever we talk about target trials, we always have to make sure we are either doing propensity score matching or just adjustment for all kinds of factors so that we can view our emulation as a conditionally randomized experiment. So I have like 15 minutes, 10, yeah, okay. So I will walk us through a brief example here. I don't want to get too hung up on it, but I had the pleasure of working with Dr. Rivera while he was a PhD student with us. He's now faculty. You should go meet him if you can. And he had been working with a group in infectious disease. And he came to me and he said, you know, Lucia, I think we could do target trials here, but I'm not really sure how we should go about it. So the first thing to do is kind of like put our COVID pandemic hats on and say, okay, well, why would it have occurred to people that you could use statins to treat COVID, right? So apparently, and I think this is probably still true, there are very few therapeutic options for improving hospital outcomes for hospitalized COVID-19 patients. And there had been some experimental studies that revealed potential possible mechanisms through which statins could operate to improve COVID-19 outcomes. I am not a biologist or a medical doctor, so I will leave that to them to explain. But it was promising enough evidence that there was actually a randomized trial conducted studying the effect of statin initiation among COVID-19 patients who were in the ICU. And this was published in 2022 in BMJ, and there was no evidence of mortality reduction. And they said the 30-day risk difference was negative 3.3%, but they had a really wide confidence interval, negative 10% to positive 4%. So, of course, because it was COVID and everybody was scrambling, there were a lot of people who said, oh, well, we have EHR data. We can just take a look and see if people who took statins were doing better than people who weren't on statins when they got hospitalized. And so there were 22 observational studies identified and included in a recent meta-analysis. And they said that there might be an overall protective association for mortality, that in-hospital use of statins reduced mortality by a lot with a relative risk of 0.0 or 0.54, which in my world is like so much. I mean, can you imagine reducing the risk by half? And they also simultaneously said, oh, pre-admission use of statins is not associated with mortality, and they found a relative risk of 1.18. So Otto and I took a look, and we identified that many of these studies, while they had tried and done a heroic job of trying to answer this question, they were flawed, right? So 17 defined the exposure retrospectively, right? Any statin use while admitted versus no use while admitted. Of course, that allows prevalent user bias and immortal time bias. And then 6 of them define the exposure as continued use if they were an antecedent user, and they compared it to never users. And 3 of those had immortal time bias, and 6 had selection bias. They defined continued statin use retrospectively. So when Otto came to me, we kind of split the question into 2 pieces. And we said, first, does pre-existing long-term statin use confer benefits, right? And second, does new statin use, so new initiation of statins once you arrive in the hospital, make a difference? And those to me are kind of 2 different questions. And so we answered them in 2 different analyses. So the first, which I'm not going to discuss so much today, we looked at antecedent statin use, which we defined as the existence of a prescription at least 30 days prior to admission, with in-hospital mortality. We compared that group to everybody else because they did not have a prescription at least 30 days prior to admission. And we did some fancy machine learning, and we calculated marginal 30-day risk differences. And we found, just like that meta-analysis had found, that the risk difference was not very big, and the confidence interval included the null. So we concluded that we didn't have evidence of a statin-associated mortality benefit. We then looked around and said, well, but the more interesting question is, once the patient is in the hospital, is there benefit to starting them on a statin, right? And so what we decided to do there was to use the target trial framework in order to answer our question. So the first thing that we did is we did our hypothetical thought experiment. So the first is who we would possibly enroll, and we decided that that was patients who were 40 years and older, who were hospitalized at Northwestern in a particular time period. This is March 2020 through September 2022, so it kind of captures a few different waves of COVID. We would want them to have PCR confirmed COVID-19. We would want them to have adequate liver function, so they didn't have a contraindication to using statins. And then no evidence of routine use of statins or documented intolerance. And then the treatment strategies would basically be within 48 hours of hospitalization, initiate statins or no statins. And per our intention to treat principle, we said anything that we saw that changed after that would essentially have been indicated and been done with the knowledge of the physician and the patient. Also, these are hospitalized COVID patients, and they were hospitalized for a long enough period of time that I felt confident in our ability to capture differences. In our hypothetical trial, we would have randomized patients, and the patient and the physician would be aware of the treatment they were taking. That's in line with the pragmatic nature of the trials that we're able to emulate. And our follow-up period began 48 hours after hospitalization and ended at the earliest of the outcome, which is death, discharge from the hospital, or 30 days after admission. The outcome was inpatient mortality, which we would assume to be confirmed by the treating physician and reported in the EHR. And our causal contrast of interest, we decided we were interested in the weekly effects. So basically, what is the effect of initiating statins versus not on mortality, essentially survival at 7 days, conditional on survival to 48 hours post-admission, because that's when treatment will be determined. We did some fancy statistics here that I can discuss more if you're interested. But we used a doubly robust estimation approach, and we used a machine learning technique called superlearner, which is an ensemble-based method, in order to adjust for the many covariates that our colleagues identified, demographics, smoking, vaccination, bunch of comorbidities, vitals, labs, and other medications. So for our emulation at Northwestern, our eligibility, if you're able to do a perfect emulation, all of these things just say same, 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 same. Now, you can never do a perfect emulation, also because randomization is not guaranteed in observational data. So the key things to highlight here are that when we do an analysis like this, our assignment procedures, and oh God, sorry. So the assignment procedures here, we have to assume randomization conditional on the measured patient characteristics that we have, which here was quite a lot of factors. And the other thing that is always different, but we talk about it kind of using similar language, is when we have observational data, because there is no randomization, in essence, you can never estimate an intention to treat effect because you don't have randomization. But what we do is we define a protocol that is the least restrictive possible protocol, which is to say, I call it the observational analog of the intention to treat effect, meaning that our treatment strategies were to initiate a statin or not by 48 hours, and then you can do whatever you want. And that's not perfect. It doesn't capture, being on a statin for the duration of your hospitalization. But we thought that that would be the easiest approach here, at least for our first pass. Okay, so what did we do specifically? We identified the individuals who would be eligible for our study. We assigned their treatment status based on whether they initiated statins within the first 48 hours of admission. We described their characteristics at admission, stratified by treatment. And then we used that augmented inverse probability weighting with TMLE approach to calculate adjusted risk differences at the end of each week. So at the end of 7 days, at the end of 14 days, 21 days, and 28 days. So what did we find? Well, there were some differences at baseline. So the early initiators of statins tended to be more male, 57% versus 49% in the non-initiators. There's some bias here. So the early initiators tended to have been hospitalized during 2020, which is kind of the earlier part of the pandemic. We didn't really see any major or alarming differences in the initial clinical presentation. So they had similar blood pressures, respiratory rates, and vaccine statuses. There were some differences in baseline comorbidities, as you would expect. If somebody came into the hospital and it looked like they were a candidate for a statin, they were more likely to be an early initiator of statins. So 81% versus 56% had hypertension, 49% versus 25% had diabetes, and 64% versus 40% had cardiovascular disease. That being said, their lab values at admission looked fairly similar. These are not on the actual scale. They are log transformed or square rooted in order to achieve more normality. And this is the result of our study. We did find that there was a risk difference of 0.5% at 7 days and 0.6% at 21 days. We actually saw higher mortality in the early initiators, which we were very surprised about. One thing that we saw that I guess was kind of gratifying in a way is that the unadjusted 28-day mortality rate was higher in early initiators before adjustment for confounding than it was after adjustment for confounding. So adjustment for all of those characteristics that I just mentioned actually brought the estimate of the risk from 6% to 3.6%, which to me indicates the presence of substantial confounding. And yeah, that's what I have for us today. Some reading recommendations, because I know everybody has time to read lots and lots of studies. Reading abstracts in epi journals is very interesting these days. So the 3 journals that I like a lot are called Epidemiology, American Journal of Epidemiology, and International Journal of Epidemiology. I also find that European Journal of Epidemiology has some interesting papers these days. This is a laundry list of things that you could go and read that should give you kind of a big picture understanding of what it is that we're talking about. I'm going to put a plug in for another center that I am a part of. You can always come and talk to us at the Biostatistics Collaboration Center at the BCC. But the Center for Epidemiology and Population Health is trying to raise its profile. And so they do consults on all kinds of study design and, things that kind of fall more in epidemiology and population health. And I'm just going to leave you with this cartoon and thank you for your attention. This has been great.